Hi, this is Tao Li, author of First Aid. In this section, we'll cover respiratory pharmacology. This section will go faster than the other talks we had with respiratory physiology and pathology. Histamine is an organic nitrogen compound that is classically involved in the allergic inflammatory response. The H1 blockers are reversible inhibitors of the H1 histamine receptor and are generally used in the treatment of allergies. There are two generations of histamine blockers, and they can be remembered based on their sedating properties. Remember that the newer second-generation antihistamines are typically less sedating. First-generation histamine blockers include diphenhydramine and chlorpheniramine. These drugs are used to treat allergies, allergic rhinitis, acute urticaria or hives, motion sickness, and can be used for sleep. Side effects besides sedation include what classic antimuscarinic side effects? Well, they include urinary retention, dry mouth, blurry vision, and delirium, among others, as well as anti-alpha adrenergic effects like hypotension and dizziness. So the bottom line is that these drugs should be used with caution in older folks. Second-generation antihistamines include loratadine, fexofenadine, desloratadine, and cetirizine. Like the first-generation antihistamines, they can be used to treat allergies and also chronic hives. Why do these drugs have less sedation than first-generation antihistamines? Because they have less penetration into the CNS. There are numerous classes of medications used to treat asthma, which truly could be a series of lectures in and of itself. However, understanding the basic underlying pathology involved in asthma exacerbations, as well as the mechanisms for the various drugs used to prevent and treat asthma, should make remembering these medications a little easier. Remember that bronchoconstriction is partially mediated by inflammation and parasympathetic tone. Therefore, some asthma medications target each of these pathways. Let's get started with the parasympathetic and bronchoconstriction pathways. Beta-2 agonists are used during acute asthma exacerbations to relax bronchial smooth muscles. So what's the mechanism of action? Beta-2 agonists like albuterol bind at the beta-2 adrenergic receptor, which is coupled to GS protein. This activates adenylyl cyclase, which increases cyclic AMP production. Cyclic AMP then activates protein kinase A, which inhibits phosphorylation of myosin and lowers intracellular calcium levels. This directly leads to smooth muscle relaxation and bronchial dilation. Long-acting agonists, or LABAs, like salmeterol and formoterol, have the same mechanism of action but last longer, so they are used with a steroid in a combination inhaler for asthma control. LABAs can be used by themselves in COPD where you have less inflammation. Theophylline is a methylxanthine that is used to treat both asthma and COPD. The mechanism of action is likely due to its inhibition of phosphodiesterase. Therefore, you get decreased breakdown of cyclic AMP and then bronchial dilation. So what are the downsides of the drug? For one, it has a narrow therapeutic index, and it has some nasty side effects including nausea, vomiting, arrhythmias, and seizure. It's metabolized in the liver by cytochrome P450, and therefore it interacts with a number of drugs like cimetidine and phenytoin. Theophylline and other methylxanthines like caffeine can block adenosine since they bind at the adenosine receptor as non-selective antagonists. So what's the clinical consequence? If you are using adenosine to break a tachyarrhythmia and your patient is on theophylline, it may not work unless you up the dose. So because of these headaches, we don't use theophylline as much anymore for asthma, but they sure make great board questions. Ipratropium competitively blocks muscarinic receptors and is used to treat COPD and asthma. Tiotropium is a newer long-acting muscarinic receptor antagonist for COPD. It mainly binds with the M3 muscarinic receptor. Now let's go down the inflammatory treatment pathway. Inhaled steroids like beclomethasone, fluticasone, budesonide, and mometasone are first-line therapy for persistent asthma, especially when patients experience asthma symptoms more than a few times each week. Oral steroids like prednisone are used to treat acute exacerbations that are not reversed with short-acting beta agonists. What are the long-term side effects of chronic steroid use? If you don't know the answer, you can pause this talk and look it up on page 296 under Cushing syndrome. Then there are the anti-leukotrienes. Xyluton inhibits the 5-lipoxygenase pathway. Is this upstream or downstream from the leukotrienes? It's upstream. So here it is blocking the conversion of arachidonic acid to leukotriene A4, which eventually begets leukotriene C4, D4, and E4. And these are the products that are thought to be responsible for allergic inflammation, bronchoconstriction, and mucus production. Similarly, montelukast and zafrolukast, which is used less commonly, interfere with the action of leukotriene C4, D4, and E4 by blocking their binding to what receptor? That's right. They block cystenyl leukotriene receptor 1, or otherwise known as cis-LT1. Finally, there is omalizumab. So what is it and how does it work? This is a monoclonal IgG antibody against IgE. It binds up serum IgE so that it can't bind to Fc receptors on what cells? The answer is mast cells and basophils. Therefore, the IgE can't bind antigen and cross-link to cause mast cell and basophil degranulation. It's kind of like an anti-missile missile, like the Patriot missile system used in the first Gulf War to shoot down Scud missiles. It's used in patients with moderate to severe persistent allergic asthma who fail treatment with inhaled steroids and long-acting beta agonists. Alright, a quick word about expectorants, which is a moderately high-yield topic. Guaifenesin is an expectorant that removes excess sputum. It has no suppression of the cough reflex as compared to preparations containing codeine. N-acetylcysteine is an inhaled mucolytic that is used in cystic fibrosis, COPD, chronic bronchitis, and other chronic bronchopulmonary conditions with significant mucus production. Recall from your musculoskeletal pharm talk that this is the same agent used to treat Tylenol overdose. Bosentan is a relatively new drug used to treat pulmonary arterial hypertension. How does it work? It blocks endothelin A and endothelin B receptors on vascular smooth muscle cells so they can't bind endothelin 1, which is an arterial vasoconstrictor, thereby decreasing pulmonary vascular resistance. What are some other vasodilating drugs for pulmonary arterial hypertension that might show up on the boards? Well, keep an eye out for calcium channel blockers, which is a first-line treatment for pulmonary arterial hypertension, phosphodiesterase class 5 inhibitors, which includes sildenafil, better known as Viagra, and prostacyclin analogs like epoprostenol, which is used in severe disease. Yes, cough and cold medicines are also board testable. Dextromethorphan is a cough suppressant related to opioids. How does it work? It binds and blocks the N-methyl D-aspartate receptor, which is a calcium ion channel that is critical in memory and learning. Theoretically, in normal doses, it reduces coughing from minor throat and bronchial irritation. It has some abuse potential because it can cause dissociative hallucinations at high doses. Pseudoephedrine and phenylephrine are commonly used in cold and allergy over-the-counter drugs as nasal decongestants. They basically act as alpha-adrenergic vasoconstrictors, so you get less nasal tissue swelling and congestion. In addition to hypertension, tachycardia, palpitations, and stimulant side effects, what else do you have to worry about? The answer would be recreation drug use, since pseudoephedrine, but not phenylephrine, can easily be reduced to methamphetamine in a meth lab, which we see all too often in Kentucky. Finally, methacholine is an acetylcholine analog and a non-selective muscarinic receptor antagonist that really has no practical therapeutic application. Instead, we use inhaled methacholine to diagnose bronchial hyperresponsiveness, which we see in asthma and to a lesser extent in COPD. If the FEV1 drops by 20% or more with an inhaled methacholine concentration of 4 milligrams per milliliter or less, then that is considered a positive test for airway hyperreactivity. Here's the methacholine challenge for a 63-year-old white female non-smoker with shortness of breath. On the x-axis, you can see the methacholine dosing concentration. You can see that her FEV1 clearly drops by greater than 20% from baseline when she reaches 1 milligram per milliliter, which would make this a positive test. So how are the results of a methylcholine bronchial challenge test helpful? Well, the test is pretty sensitive. Do you remember the mnemonic SNOUT from the biostats section on page 51? So here, if it's negative, it essentially rules out asthma. However, the test is not very specific. The mnemonic here is SPIN. A specific test can help you rule in a diagnosis. So here, if it's positive, then it may help you make the diagnosis of asthma with the right clinical context. But you have to worry about false positives because other conditions can give you a positive test like smoking, upper respiratory infections, allergic rhinitis, and gastroesophageal reflux disease.